Well, we've heard a lot of interesting things about measuring flow. We've heard a lot of interesting things about total arterial revascularization. So I think it leads us to have Philippe wrap it up by asking the question, have we succeeded in improving the results of coronary artery surgery?
Well, thank you very much, and again for the invitation and for this, for helping building this session today. I think it was quite interesting. So I will repeat some of the things that we have already said to some extent, because I think that David, for example, has already touched upon numerous aspects to explain if we did improve the results of CABG. I think obviously after CABG was started, we can agree that one of the most seminal turn point was the introduction of the internal mammary artery used to bypass the LAD first. And I think not even the most difficult cardiologist would argue that the NIMA to the LAD is probably one of the safest operation in cardiac surgery, at least safest for the long term. I don't mean that there isn't any risk. If you look at the results 10 years after the seminal publication by Floyd Loop, by Cameron here in the New England Journal of Medicine, you can see a very significant 15-year survival of a LIMA to the LAD as compared to a vein graft. Now, it doesn't mean, obviously, that after 15 years, all patients are still alive. You can see there that at 15 years, we have lost probably about 30% of the patient, but there is natural progression of the disease, and also they have numerous comorbidities. The second aspect that, again, David touched, which I think is very important, is the question of bilateral artery mammary. Still underused. If you look at the syntax trial, I think less than about 15% of the patient in the syntax trial got double mammary artery, which is a pity. We probably could have had even better results if we had used both. The good thing is there is similar patency of LIMA and RIMA when placed to the left coronary circulation, either the LAD or the SERG. I mean, if it was the right coronary artery, the slide will be certainly different. So this article by Tatoulis a couple of years ago, I think, is also important. There are numerous studies we can summarize. I'm not going to repeat what Professor Taggart says, but 2 mammaries is certainly better than 1, at least in large subgroups of patients. Now, in terms of survival, is it better to use 2 mammary than 1? It certainly depends on the life expectancy of the patient. You can see here comparing a single internal mammary artery. That's a publication from Bruce Little back 15 years ago in JTCVS. Well, the curve actually do diverge, but after 5 years, not before that. And summarizing 10 years ago, a lot of studies, again, more recent studies may show some different results, but not that much. There is no survival difference at 5 years if you compare single and bilateral IMA. However, you do have survival benefit at 10 years. So I don't think it makes a lot of sense to use 2 mammaries in someone who is 80 or 85, unless you don't want to touch the leg, unless, I mean, there is no veins, or unless maybe, now you can argue the patient is diabetic and I don't want to touch the leg. That's a possibility. You also have the radial artery. I'm not going to reopen the discussion again fully, but certainly for younger patients, up to 70 years of age, probably bilateral artery mammary is better than 1. The second main point of my talk is the syntax trial. Could we imagine a syntax trial in 1970? Probably not. Well, from the cardiologist's point of view, obviously not, because there wasn't any stent. So they would say it's a major progress. But if you look at the population of patients that we did operate in the syntax trial that was performed between, I think, 2003 or 2004 and 2008, actually there were pretty sick patients overall. So the design of the syntax trial by itself, I think it's a form of progression of our profession. You know that 1,800 patients were randomized, 900 went to surgery, 900 went to PCI, and then you had the registries for patients that could not be offered both techniques, could not be randomized. I think there are probably two very important innovation from the SYNTAX trial. One is the heart team, where a surgeon and cardiologists do speak together and are supposed to review the card together, and by extension are probably supposed also to discuss the risk of the patient. And the second one is the SYNTAX score by itself. Now, the SYNTAX score is imperfect. We have already now a SYNTAX score 2, a post-CABG SYNTAX score. There are a lot of variation, but at least that's something quite objective when you know how to calculate it. And we know the results of the SYNTAX trial. Remember that the primary endpoint was non-inferiority of paclitaxel-eluting stent, so PCI with taxus, at 1 year. And this non-inferiority was not reached. Therefore, any further consideration and discussion is actually hypothesis generating. We have to understand that. That actually paved the way for the EXCEL trial, for example. So at 1 year, it can be summarized that death, CVA, and MR rates were similar between CABG and PCI if you look at the overall 1,800 population, not according to tertiles. Stroke was increased in CABG versus PCI, and repeat revascularization and MACE were significantly increased in PCI versus CABG. Now, that's a population with rather large extent of coronary artery disease by definition, 3-vessel disease and or left main. So we end up with 12% of MACE in our population of CABG and 17.8% with PCI. Now, at 5 years, that's the final results. We may not have more. All-cause death at 5 years is not different. But cardiac death at 5 years is different with an almost 4%, actually 3.7 absolute risk reduction comparing CABG with PCI. And I think by itself, it's an answer to the question that we actually improved the result of CABG as compared to 20 years ago to have a cardiac death at 5 years of just over 5% in these patients. If we look at MI, we have also a benefit of CABG. The difference there is almost 6% absolute risk reduction in favor of CABG. If we look at CVA, well, it was more worrisome at 1 year. I'm not saying it's not still worrisome. We probably should aim very significantly at reducing this incidence, but it's not any more significant. There is a trend, 9% is the p-value in disfavor of CABG, with a 5-year CVA rate of 3.7% as compared to 2.4%. All-cause death, CVA and MI, so what we call the hard endpoint, 4% reduction in favor of CABG, 16.7 versus 20.8%, p-value 3%. Now, obviously, the results of the SYNTAX trial is in favor of CABG, looking at repeat revascularization at 5 years, and this is especially true for the intermediate and high tertile. MACE at 5 years, we already mentioned that it's very much in favor of us. But remember, we still have a 27% rate of MACE at 5 years. That's a high-risk population, and we should follow this patient and insist also on the importance of secondary risk prevention. Now, that's actually a slide that I share with David. Standard CABG with coronary bypass grafting versus OPCAB and the risk of stroke. We know that conventional CABG with coronary artery bypass grafting, there is a risk of stroke for every manipulation, cross-clamp, aortic clamp, cardiopulmonary bypass, performing the anastomosis. If we use off-pump, we eliminate numerous of them, but we do keep the vein to the aorta with the side biter, usually, which we know does significantly increase the risk of stroke. while if we use OPCAB and composite arteries, everything is eliminated. And I bet that had this technique be used in the syntax trial, the incidence of stroke would be lower. Now, obviously, again, you need experienced surgeon to get that. Otherwise, you will end up with higher repeat revascularization, MI, and other problem. So if we are well experienced, and again, it's a question of training and volume, composite arterial grafts based on in situ bilateral IMA eliminates the need for coronary pulmonary bypass grafting, and any aortic manipulation minimizing the risk of stroke. And I think stroke is terrible. The patient, they don't care that much about repeat revascularization. They do care about MI to some extent, but they are afraid of stroke. And that's quite normal. The third point I would like to address in improving the results of CABG is the importance of ischemic myocardium. I already mentioned that in previous talk today. There was the seminal publication of Ashamovich in Circulation in 2003 and an update one in European Heart Journal 3 years ago showing that if you don't have significant ischemic myocardium, use optimal medical therapy. And mechanical revascularization, either by PCI or CABG, do only benefit the patient who has between 10 or higher than 10 or 12.5% of ischemic myocardium. Below 10, 12%, there is no benefit. And that's a huge series of almost 14,000 patients undergoing adenosine or exercise stress SPECT myocardial perfusion scintigraphy. And according to that, it has already been discussed extensively today, but I think it's really important, although we don't have all the evidence we need for CABG. We do have it for PCI. Routine measurement of FFR, fractional flow reserve, in patients with multivessel coronary artery disease or undergoing PCI with drug-eluting stents significantly reduces the rate of the composite endpoint of death, non-fatal MI, and repeat revasc at 1 year. Look at the comparison between FFR-guided PCI and angiography-guided PCI. Obviously, there is a higher number of stent, but there is also very significant risk reduction when the patient are revascularized with an FFR-guided technique. And I trust that to some extent that will be the same for CABG. We also have new modalities to assess FFR. They still need some development. But if you compare FFR measured by invasive angiography and FFR measured by new, very sophisticated CCTA, they are very similar. Look on the right, invasive angiography of FFR of 0.74, and below lesion that looks significant, it's actually not significant, 0.84, and if it's compared by the CT, it's very similar, 0.74 in both cases, 0.84 and 0.85. Now you have a question of radiation, obviously, and so forth, but I think it's also a promising technique. The fourth point I would like to address is the importance of training and volume once we start to work. The relation between volume and outcome of coronary interventions, systematic review and meta-analysis. Actually, you can see, and I don't need to explain that much, on the right, that numerous studies favors high volume. We had the opportunity with William Waynes, who was chair with me of the previous guidelines, to write an editorial or a review of that in European Heart Journal 4 years ago. Experience with revascularization procedure does matter. Low volume means worse outcome. This is true for PCI. This is true for elective PCI. This is true for PCI for an acute event. We specifically mentioned in the guidelines that law centers should not do middle of the night PCI for STEMI, for example, but that the patient should be transferred. And the same recommendation of volume apply for CABG. If you look, for example, at the syntax trial, there was, though they don't discuss that much, 12-month MACE results according to site. And it's not really linear, but there is a relationship between MACE rate and the volume of the procedure, CABG versus Stent. So in the guidelines that we did 4 years ago, and that will be, a new one will be released later this year, we insisted on the importance of ischemia. As I've already said, ischemia should be documented if we want to improve prognosis. You can also perform CABG or PCI for symptoms. That's another story. What we also said in the guidelines, and I will shortly conclude my talk, is that it's important to discuss the patient within the heart team. If you look at the slide here that David already showed from another angle, and I think it's very important, first is the title. I mean, those are patients that are suitable for both procedures, both from an anatomical perspective and from a risk perspective. That's patient that you can randomize, for example, in the syntax trial. And we have a lot of green light. In most circumstances, the anatomy for proximal LAD, 3-vessel disease, left main, favor CABG. By the way, that was the first guidelines in which we did introduce PCI should be considered for isolated or ostium shaft left main. The American followed about 1.5 years later at the end of 2011. But also, we have a lot of green light on the CABG column. There is a lot of yellow light on the PCI column, which means that it should be or may be considered. So for a lot of these patients, although CABG is a very good option, PCI is also an option, and that's why these cases should be discussed within the heart team. Obviously, in the most severe patterns of CAD, we have seen that with the syntax trial and also with numerous very large registries, CABG appears to offer a survival advantage as well as a marked reduction in the need for repeat revascularization. As I said, procedures should be performed in hospital with protocols. Arterial grafting to the LAD system is indicated, 1A. Complete revascularization with arterial grafting to non-LAD coronary system is indicated in patients with reasonable life expectancy. We voluntarily were quite vague because it's very difficult to give, to say 70 or 65 or 75 because there is no real data. That will be purely expert opinion. Minimization of the aortic manipulation is recommended, and graft evaluation is recommended before leaving the operating theater. So all these recommendations will, I think, further improve the results of CABG. And very importantly, I think one thing that will keep us on board and keep us improving the results that we deliver to our patient, to the hospital and to the society as a whole, is to work together with the cardiologist as a heart team. Thank you for your attention.
Does anyone have any questions for Professor Kohl? Okay, well, I think on that point we can wrap up this session. It's been a very good session. I think we've covered a lot of important areas. So I'd also like to thank the audience for having stayed and behaved in such an interactive fashion. Thank you.
Good.